Dear all, we're here at the ESC Heart Failure Conference in Paris on behalf of the CVCT Global Clinical Trialist Forum. I'm here with Dr. Roy Gardner from the Golden Jubilee in Glasgow, UK, and Professor Martin Cowie from the Imperial College London to discuss findings from the MULTISENSE trial, additional findings that will be presented tomorrow. And thank you very much for being here. And
thank you for inviting us.
Yeah, thank you. First of all, in the published MULTISENSE trial, we have a sensitivity of finding these heart failure events of around 70%. And this comes at a cost of approximately 1.5 unexplained alerts per year, which far exceeded the pre-specified validation endpoints. Do you think these pre-specified endpoints were ambitious enough? And what do you think about these findings? Are they satisfying in your view?
Okay, so I feel that we do need a prospective trial running an algorithm to look for patients who are having heart failure events. I think if you look at the heart logic algorithm with a nominal threshold of 16, you were 10 times more likely to have a heart failure event when you were in a period of alert than when you weren't. So in fact, the event rate ratio when you look at people out of alert is very small indeed. So it's 0.08 events per patient year. So if you're out of alert, you're very unlikely. So this is a reassuring group. It is true that if you're in an alert, you're 10 times more likely, but still the event rate ratio is less than 1 patient per year. So it's 0.8, but it's a tenfold ratio.
Along this line, you also had the median time from an alert to an actual event was around 39 days, if I recollect it correctly. Yeah. What would be the potential action in an intervention trial? Would it be to call the patient in for an outpatient, subacute outpatient visit, or how do you see the design of an intervention trial?
So that's a very good question. I think we all appreciate that acute heart failure doesn't necessarily be 1 minute you're fine, the next minute you're decompensated, and these things do build up over a period of time. What we also want to avoid is an early alert with a knee-jerk reaction, meaning somebody's brought into hospital, and we've seen that from clinical studies in the past. It depends how the healthcare environment works. In the United Kingdom, I foresee an area where heart failure nurses could be alerted by the device to monitor the patient more closely. So, as I said, if you're in an alert area, these patients are at risk, and these could be kept an eye on more closely. So, healthcare resources, which are limited, could be prioritised for those individuals. In most cases, I think it would require an adjustment to diuretic, usually upwards, for a period of time, monitoring, of course, the biochemistry.
And also along this line, in terms of costs, this might produce more visits to the clinic. Could you imagine that you could cancel routine visits and rely more on alerts like this to guide your ambulatory visit for your patients, instead of seeing them routine-wise every 3-6 months, to only see the patients who has alerts?
Well, as the algorithms get more and more interesting, some would regard complicated, I think it does give you more data about the patient remotely. Perhaps to give us confidence that patients who are in a low-risk group, and in fact if we split it into 3, so rather than a high-risk and a low-risk group, the event rate ratio looks to be almost 30 times more likely if you're in a high-risk group. So you could actually give somebody a non-physical hug of reassurance if they're in a low-risk group.
And then my final, maybe the perspective would be to compare with some of the other trials which have been conducted, including the remote heart failure trial presented by Dr. Cowie last year at the ESC, and also the MORE HF, I think it's called. These are trials who already took in interventions, and the remote heart failure didn't show any benefit. Why would you think that this system would show a benefit? Is it more advanced? Does it have more finesse, or what's the potential with this system, or this heart logic score?
So I would of course love to say it's more advanced. It's looking at physiological things that we would expect to happen. So, you know, the third heart sound becomes louder, the first heart sound becomes quieter. All of these things we could predict are going to be a helpful thing, but it all boils down to what happens when we get an alert. And that's the most important thing going forward. There's a study called Manage HF, which is due to start, but it's a case of what you do with the information that comes out of it, and I think that needs to be absolutely firmly in place before a study starts. So the intervention needs to be very clear.
Do you have any further comments regarding this issue or the potential of a trial here?
So I think this is really interesting data, and I think there's been a long journey to try and develop an algorithm that can actually use multi-parameters to identify patients at risk, so risk stratification. So there's lots of publications over the years. This looks promising, and you can actually identify a higher risk group. The absolute risk is still relatively low, so the big problem in all of this is giving data to individuals so that they don't overreact and increase their activity without improving outcome for patients. But this looks the most promising algorithm, and as Roy says, physiologically it makes sense, it looks attractive. You've now demonstrated this and looked at the data in quite a lot of depth, which is great. But I think the plan to do a prospective trial, giving the information to doctors and heart failure teams is absolutely vital. And the FDA wants this. They like the algorithm, sounds great, but demonstrate to us that actually when you release it into a healthcare system, as Roy says, it's actionable, it reduces outcome, bad outcome for our patients, and the data flow is manageable. So I think it's an important step in the process. Now let's go and demonstrate it prospectively.
And have we learned our lessons from these previous trials? That
Time will tell.
Okay. Thank you very much for this interview and for coming here and talking to us today.
My pleasure.
Okay.
Thank you very much.